Okay, so now we have some questions. I've been waiting for this session because we've been transitioning from a sports supplement and a fitness supplement into health applications and potential adjunctive therapeutic roles. We have 3 physicians here that have been in the trenches for many years. And my first question is, you've seen it all from the beginning to where we're at now. Where do you think we need to go to get the medical community to be more receptive and open? Is it doing what we were just talking about, getting the general health, or is it we keep on pushing the envelope on the medical aspect? So let me ask Dr. Tarnopolsky first, and then we'll move it down.
Yeah, thanks very much. One of the biggest challenges we have is, number 1, that creatine makes you fat. Number 2, creatine damages your kidneys, and we just can't get away from this. I've had so many patients who have horrible life-threatening disorders like MELAS syndrome, strokes and seizures, and patients dying left, right, and center with this disorder. And when they're going through pregnancy, for example, all of their supplements, they pull them off, which really is the wrong thing to do. I mean, these patients, as we've heard, when you're giving birth, it's not just the smooth muscle, but also skeletal muscle contraction. They're generating lactate, and they're already impaired. And yet, time after time, our patients with muscle disease and mitochondrial disease are taken off because it's going to damage their kidneys. And I think from a public health perspective, the number 1 thing that we see is, oh, I get bloated and it makes me fat. So the misinformation is rampant. And physicians who really should know better, follow these myths, and they don't read the real research. For example, we did a study on Duchenne dystrophy, which I mentioned, and halfway through, half of my subjects were calling, or the parents were calling, and saying, we want to drop out. And why they wanted to drop out is that there was that hypothesis paper, I think it was Rima Kadura-Duke and Marcus Wyss wrote a hypothesis that there were cancer-containing compounds. I was going up the escalator, and there was a fellow, MD, PhD, who was an epidemiologist. He said, oh, Mark, did you hear about that randomized trial that showed that this is causing damage? I said, wait a sec, randomized trial? What are you talking about? And it was a hypothesis paper, which then got blown up in the press, and then a physician who should know better thought it was a randomized trial showing that it would cause kidney damage. So the misinformation is rampant. It's really a challenge for us to try and turn that around. But another point I'll just make too is we're going to have a huge uphill battle if we ever can get creatine into moms with high-risk pregnancy. So as a pediatric neurologist, I see children who are born with encephalopathy, and the question is it hypoxic ischemic encephalopathy from decreased blood flow during the perinatal period, or is it a genetic disorder? And then I see them again because our clinic is beside the spasticity clinic. 90% of those kids are cerebral palsy kids who've had hypoxic ischemic encephalopathy. So look at the impact on their life. 80 to 90% of those kids will never get a job. They won't get married. They will not contribute to society, and they have a horrible quality of life. And risk-benefit for a supplement, which is part of breast milk, part of what we're eating, in a woman with high risk, for example, if they've got a previous history of preterm labor, if the child is small for gestational age, really we should be putting these people on the supplement. But what happens is that it's a throwback to thalidomide. And I think that's where it all started, is, decades ago, people were put on thalidomide for nausea, and then we saw the consequences. And somehow people are sort of extrapolating from a drug with unknown side effects to a natural product of breast milk and in your body. And I think we're stuck with that legacy, and it's going to be very difficult. I wish Stacy was here to comment on this because I want to talk about that earlier. But there's just so many ways in which myths are still perpetuating and blunting us to really see the medical potential of this. But the lovely work that we heard from our colleagues here about the kidney, I think that's really going to go a long way to help dispel the myth. And as you probably are familiar, we did a study in older adults where we truly measured creatinine clearance with urine excretion for 24 hours, and it was not affected or even went up a little bit when people were on creatine supplementation. And yet the myth just persists about those 2 main areas. And creatine causing cancer, don't even get me going.
Dr. Balestrino, same question. What's it going to take to get the medical community more aware and adopting of potential applications of creatine?
Well, first of all, I agree with Mark that we should fight misinformation, so we should fight all the negative myths about creatine. I think we need two more things in addition to fight negative myths against creatine. Number one, we need specific information to physicians. It is well known that physicians have a latency, let's say a learning curve between something that is novel, a new discovery, and its implementation in medical practice. And this is kind of physiological in medical or pathological, if you wish, but it is a fact. About 10 years ago, I contributed to a paper that analyzed the attitude to prescribe anticoagulants to people who had cardioembolic stroke. Now, to put it simply, people who have had a stroke from atrial fibrillation, they do need anticoagulant therapy. And this has been well known for at least 20 years. But 10 years ago, in my country, which is Italy, but I'm sure this happened all the world over, you went to the general practitioner and you told him, you prescribe an anticoagulant to your patient, so and so. And the usual response was, no, because he is too old. No, because he will bleed. No, because he doesn't want. So there was, even if the data were there, the physicians didn't know them, or either they didn't know or them under-evaluate. So now, all physicians in Italy prescribe anticoagulants, but it has taken years of information and lobbying, not really lobbying, but discussing and bringing the data to the general practitioner in a way. So this is something that must be done to implement and advance knowledge in the medical profession. And it is true for creatine, it was true for anticoagulant, I guess it is true for everything. But then again, this is not sufficient because something else needs to be done, and that is you have strong data to show to the physicians. If you go to the physicians and you show them so-and-so data, they will be reinforced in their skepticism. So you need to have strong data, like what we are showing here, we are listening here. And so with strong data, you have to go to the physicians and inform them. And I think that this is what shall be done in the next years.
Same question, Dr. Ostojic. Do we need to have nutrition education in medical school?
Thank you, Rick. This is an excellent question. No. There is a big problem with education in nutrition for medical doctors all across the world. I had a very interesting meeting last year in Chicago. We had evening a dinner with leaders of American Society of Nutrition. Most of those guys are medical doctors coming from Columbia, from Harvard, and stuff like that. And I was at the table, and everybody is into how to, provide a good nutritional education to medical doctors, both in Europe and in the US. So this is a big problem. So somehow there is no strong curriculum development for medical students by the professional association related to nutrition in the US specifically. How to do that, I'm not really confident that I have any kind of answer because the similar situation is in Europe as well. It's different because different countries embrace a different approach how to educate that. But I think this should be addressed by approaching the leading professional societies. And our group should work towards preparing a kind of guidelines, good practice material and stuff like that in critical journals like American Journal of Clinical Nutrition, because the editor-in-chief is organizing that dinner coming from Harvard, the guy. as well as European Society for Clinical Nutrition. So you probably know about that from our last communication. Instead of publishing in the journals who are perfect for exercise scientists, physiologists, and nutritionists, we have to publish our data or letters or opinion pieces in clinical nutrition, in Lancet, in JAMA, in that kind of journals, at least as letters or opinion to spread the right word, because it's very important, in my opinion, to win those guys who are not supporters at this moment because they do not have enough information. So education is just part. But I'd like to address something else as well. I think the industry is a critical player here because many people, many colleagues of mine, they see creatine as something, in a big box, powdered, bulky person, on the cover, this is something not for me. So preparing different products, embracing different kind of dosages, different protocols, like Revitalis. So I strongly support that idea. This is something different. This is for us, although it's the same molecule, but a concept should be different, and that should be pushed strong in the years to come. Thank you.
Okay, thank you. We're getting lots of questions online as well as in the audience. So let me go to one of those. If I'm an obese person, undergoes Ozempic treatment, but has strength and doing strength and training and a high protein diet and supplements with omega-3 and creatine, do I have side effects, or do the side effects diminish? In other words, can you nutritionally alter some of the potentially negative effects on muscle from Ozempic?
Yeah, so it's something we've thought a lot about. As people are aware, when you lose weight, if it's bariatric surgery, if it's GLP-1 receptor agonist, or even moderate caloric restriction, you will always lose muscle. The best data is New England Journal of Medicine. Villarreal is the first author. I believe it was about 7 or 8 years ago. They put people on a moderate caloric restriction of approximately 700 calories, and they randomized them to endurance, resistance, or endurance plus resistance exercise to see if they could attenuate the bone loss and the muscle loss. So keep in mind that the magnitude of weight loss over that 6 months was about 50% of what you see with semaglutide or tirzepatide. In spite of that, resistance plus endurance plus 1,500 kilocalories of, 1,500 milligrams of calcium, 1,000 units of vitamin D, and counseling from a nutritionist for high quality protein at greater than 1 gram per kilogram. Do you think that prevented the loss of bone or muscle? No. So with all of that not preventing the loss of bone or muscle, it's a real challenge. I really firmly believe, based on our data, and we actually have a big grant into Health Canada to look at this, that creatine is going to be one of the critical factors. I think the quality protein is critically important because when you just say protein, as you saw, the quality of protein is critically important. But I think good quality protein, creatine is an important aspect of that, but it's going to be really, really hard to attenuate that loss. But we have to try, and we have to, I think, biased opinion, multi-ingredient supplements is the only way we're going to do it.
Very good. Anybody else have a comment related to that? Okay, so let me go to another question. How should we best assess creatine intake? And what recommendations would you have for healthy adults on the minimum or correct amount of creatine to have in their normal diet?
Thank you. I get that kind of question very often. In the past few weeks, I gave 2 interviews to Norwegian media, and both journalists asked exactly the same: how to assess the creatine level. And of course, I told the guys, it's best way how to do it is to measure the level of creatine in the muscle and the brain, but it's experimental. And embracing this simple, I think, strategy to get at least creatine level in the blood, although it's not a perfect indicator, it might be a good way how to do it in terms of understanding the creatine status. Regarding the dietary intake, it's probably best way how to do it through the classical ways to, like 24-hour dietary recall, which is not a perfect one. But if you're going to consider the, public approach and population research, I think it's still, although people are underestimating or overestimating, I guess it's good enough for a population-based research. But in terms of the maybe something that is feasible, I think people should consider creatine malnutrition as a kind of there is no golden standard, but if you have fatigue, if you feel fatigue, if you have a kind of brain fog or something like that, that might be an indicator, okay, I might have a creatine deficiency coming from the food. Let's measure at least creatine in the blood. We definitely do some additional analysis, and my students are going to present something this Saturday. Creatine in saliva might be something that is interesting as an alternative for future, because we find out some interesting information about it. So yeah, we have to try to find a better marker to see what is the creatine status coming from the food. But also I can see, in addition to that sometimes if we are not getting enough creatine by itself from the food, we are getting a lot of creatine precursors from the food. And we did also some research, and we submitted that recently to try to estimate how much an average body produces creatine endogenously coming from the dietary sources. And, hopefully I will have some information to share anytime soon. Thank you.
Very good. So let me go to another question from the audience. So how safe is creatine for somebody who's on antihypertensive medications or diabetes medications?
Very safe. Why should it not be so? It's simple. I mean, there are myths, as Mark was saying before, there are myths about creatine. Why should creatine be harmful to anybody who takes antihypertensive medication? I don't see any reason.
If you look at our last special issue, there's a paper on vascular health, there's a paper on diabetes that Bruno mentioned earlier. If anything, it's probably beneficial, especially if you're doing training along with it to get the benefits. You're going to get a greater training and health adaptation from it. There's even data on lowering cholesterol in some studies.
I agree. One of the best evidences that I know about safety of creatine, even in frail people, in elderly people, has been the trial that was carried out in the United States for creatine in Parkinson's disease. Now, that trial had negative results. So the trial demonstrated that creatine is probably not useful to improve Parkinson's disease. But it was a trial that monitored Parkinsonian patients, which is elderly people, frail people, for, I don't remember if 5 or 10 years, anyway, a long period of time, and they got an average of 10 grams of creatine per day. So they got, these elderly, frail people got an average of 10 grams creatine per day for 5 years. And the adverse events were just the same in controls and in treated patients. I'm sure that many controls and many treated patients were taking antihypertensive medication, and no issue was found on the subject.
So along that line, one question for our folks who did the renal function hemodialysis studies. Did you measure homocysteine? And the reason I mention it is that back in the early 2000s when we were at Baylor, we actually did a couple studies on end-stage renal patients who were getting dialysis, giving them creatine to reduce their homocysteine level, which is one of the precursors in the pathway. Did you guys measure that at all?
Not in the dialysis patients, but we did measure it in the kidney transplant recipients cohort. But we didn't see what we expected, exactly that if they had a higher creatine intake, there would be less synthesis or less methylation demand. we didn't see the expected results, but then again, those were measured in samples that have been frozen and thawed and frozen and thawed, so we weren't sure how stable the homocysteine measurements were, because we saw some more things that weren't completely lined up, so we couldn't say for sure. But it's definitely interesting, and we still have some samples from the dialysis cohort, but those have also been frozen and thawed. So
I raised that because the studies were a little bit mixed, but the whole rationale was it's good to give renal patients creatine who are on dialysis because of the potential benefit from homocysteine. And Mark's got some experiences with this in some of his colleagues. Would you share your perspective on use of creatine in folks with end-stage renal disease?
Yeah, so I've convinced one individual who came to do a PhD with me, Scott Brimble. He's the head of nephrology at McMaster University. And we did muscle biopsies on patients who are undergoing dialysis treatment. And the one thing that's very clear in the muscle, there's significant mitochondrial dysfunction in the muscle. I just reached out to Scott to see whether we have the creatine analysis or not. I can't remember what it showed, but clearly they're compromised, as we've seen if we do intramuscular creatine measurements. And so Scott actually does give creatine to all of the patients that are undergoing hemodialysis. Number one, let's say there's a chance in a billion that the creatine is causing kidney damage. Not to be flippant, but who cares? Your kidneys are pooch. You're on end-stage hemodialysis. And the tiny, infinitesimal zero evidence risk to damage to your kidneys, which are already pooch, but the very real damage to your brain, your heart, all of the other tissues and the benefits that they could confer by being chronically creatine deficient, I think it's low-hanging fruit. And it should be standard of care. Everyone who's becoming creatine deficient through hemodialysis should be replaced. I would advocate they also should be on a mitochondrial enhancer too.
So along with myth busting, somebody also had a question about renal function, but should they have a high protein diet and should they be exercising and should...
No. Well, exercising is low-hanging fruit. I mean, all the drugs and all this BS about rapamycin and all this garbage that's out there to extend lifespan. What's the only proven therapy to extend lifespan in humans? Exercise. Endurance exercise on a regular basis increases lifespan by approximately 4 years, and it gives you about 10 years of health span extension. Nothing else has been proven to do that. And so I think clearly exercise is beneficial. We know, too, that it's one of the most important countermeasures to the sarcopenia that these individuals experience. Higher protein, for sure. Again, the kidneys are already pooch, so this concern that your protein of more than 1.4 grams per kilo is going to be deleterious to your kidneys, that ship has already sailed. So now you have to look after your muscles and the dysfunction. I mean, if you want to see sarcopenia, when we were biopsying these folks, it's like my muscular dystrophy patients. It was hard to find muscle. I had to pull it off the bone in order to actually get a sample because so many of these patients were profoundly sarcopenic.
Go ahead.
We also looked at protein intake in the kidney transplant recipients cohort and the dialysis cohort, and in both we saw that a higher intake of protein, which we then assessed by the urinary urea excretion, so really the biomarker-based method, we saw that it was strongly associated with less mortality in the kidney transplant recipients, but also longer living grafts, and less renal function decline, contrary to what's often believed that if you have CKD before dialysis that you should restrict your protein intake. And I can even take it one step further, but that's a little bit more speculating, that it's all the studies that have shown that a high protein diet is bad for the kidneys. They also used serum creatinine-based estimations, almost all of them. And if you take less protein and you lose muscle mass because of it, then of course you will have a lower serum creatinine and it will look like your eGFR is stabilizing or even going up, and it will seem good, but in the long run, it might even be bad, because also in the PREVENT cohort, which was the patients at risk of CKD, even there we see that higher protein intake is strongly associated with lower risk of mortality. And that's with the biomarker-based methods. We don't have food frequency questionnaires. There are some other studies from other groups that show that high protein is bad for mortality. But I can argue that urinary urea-based assessment is probably more reliable than a food frequency questionnaire, where portion size estimates and socially desirable answers might play a role and stuff like that. So I really don't think that a high protein diet is bad at all, but maybe that's a little precautious.
Well, the International Society for Nutrition completely agrees. And we've done position stands on protein, essential amino acids, et cetera. But the myth's still there. And what people often do is combine creatine and protein. And the worst thing you do as you get older is have low protein intake and not enough creatine in your diet. So make sure your protein intake's fine. We supplement. We have people taking creatine in our studies that are doing exercise and trying to promote fat loss and maintain muscle mass. Because you look at mortality, when you start losing lean mass, the prognosis is not very good for very long. And so that's the message we say. If you're getting older, lift weights, eat a good quality protein diet, make sure you're getting enough creatine, because it's essential to keep muscle mass as you age, prevent falls and all other type of things that are associated with aging. Okay. All right. Any other comments that you might have? I know we're kind of trying to finish up a little bit earlier today, we can go out to our phenomenal dinner tonight, Bavarian dinner. But Robert, what are your kind of thoughts after hearing the medical aspects? I know the industry's always worried that the regulator is going to say, well, we shouldn't say this about this or this about that. I'm tired of that, folks. There's data. Show me the data, and we ought to be presenting and educating people what the data is, let them make an informed decision, and getting the information to the healthcare practitioner. What are your thoughts?
Well, I absolutely agree with what you're saying, and I think same like everyone in this room, we consider ourselves as true creatineers because we believe and we are convinced that this molecule can improve the quality of life of many people. And we see that as an obligation, right? So basically it's two things which are important. One is never compromise on quality, and the second is support science, because we are very conservative on that. We would never do or say anything which isn't backed up by science. So quality meaning that we are the only creatine producer producing under GMP standards. We are, by the way, the only producer outside China. This means the only one really being compliant with all laws regarding quality, labor, environment, and so on. By the way, we're not only producing creatine, but as well all raw materials, and in some cases even the grandfathers of creatine we produce in-house in Germany and nowhere else, right? And this allows us really to give a consistent, very high level of quality. And science, of course, is so important because we need to tell, we need to prove, we need to question. Science is maybe even more questioning than proving. And we are really doing what we can to support this. On one side, platforms like these days here, and by the way, thanks a lot for everyone participating, to exchange ideas, to get new ideas, to question what we're doing. We're taking the burden of all regulatory work, health claims, novel food, you name it. And we, of course, are actively supporting studies as well. So at this moment, we're supporting more than 20 studies worldwide. And I really want to invite you, if you plan a study, if you need creatine, come to us. We are at any time ready to support studies with free creatine, because we're eager to know, we're eager to prove, and we are eager to tell people what's happening there. And the medical application has grown so much in importance. I think COVID was maybe a catalyst for that, but it began much before that. I remember in the mid-90s when I first heard the name of Theo Wallimann, and it was really spearheading what we're doing today. And like Sergej mentioned before, it's a lot about explaining and getting rid of this myth of creatine is doping for bodybuilders, right? And that's still, unfortunately, very persisting in the market. That's one of the reasons why we created with Crea Vitalis a brand which is dedicated only to health applications, to really help people accepting the idea that there is a molecule which can do more than exercise. And don't get me wrong, Crea Pure is still gold standard gold standard creatine in sports and very important, but we have to offer options to people to understand and accept that there is more out there. And yeah, like I said, we do a lot there. So we are asked very often, well, how do you know that it's your creatine or not? It's very easy. We got two brands. So where's the camera here? I have to do that, sorry. So one is Crea Pure, and the other one is Crea Vitalis. And you will see it easily by the logo on the jars of our customers. And that's maybe important as well. We don't give the logo to everyone. So we're really questioning and checking the quality. We're even ghost shopping to make sure there's so much fake out there. And we really go after that because as a community, we must not risk that anyone is getting a creatine with a bad quality. We have seen crazy things like mercury, like lead. Once we even seen peanuts. Don't ask me how they get it in. But it's for the reputation of our work, it's very important only to have the best quality. And the more we go into medical applications, and a very important example I'm using is, if you think about dialysis, so we start getting in direct contact with human blood, how close you can, or how can you get closer to the human body than that? And we see that as as obligation and a responsibility.
So I'm waiting for the day we see on packages, instead of keto-friendly, we say creatine, 1 gram or whatever it might be. So they consumers, I can consume that.
Yep.
And then add food, creatine to food to make it easier for folks. And one thing you mentioned on World Health, protein's expensive. And in poor countries, we can't get quality protein, right? And so maybe a little bit of creatine added to food stuffs that we're providing to help with start kids might go a long way to help promote health. Long way away, but that might be
Well,
a way.
that's a very good point, Rick. We have checked what is really the cost of a daily dose of classical supplements. And you will see the creatine by far is the most efficient and economic one. If you go to protein, you immediately are above €1, €1.50 per day. And if you go to omega-3 and other ones, very quickly everything is going up even more than that. So it is inexpensive, it is very efficient, and well, you all here know that. Just take it and you will feel the difference. It's really like that.
And I'll add one last thing. Saturday we'll do our safety unveiling of this huge study. And 95% of all studies have been done on creatine monohydrate, well over 800. And almost every one of those have been CreaPure source, German creatine. So we don't tell folks what to buy, but you should certainly go with what's been tested. And so that's something to consider.
Couldn't agree more.
Thank you all for being here online as well as in person. Look forward to a great evening this night, and we'll see you tomorrow morning. Thank you.